I'm presenting today the results of the Pet Neck trial on behalf of the Pet Neck trial group. Traditionally, the standard of care for advanced nodal disease being treated with chemoradiotherapy is a planned neck dissection. This could be done before or after the chemoradiotherapy. 40% of neck dissection specimens have residual disease on histopathology, and there's some evidence to suggest that a neck dissection confers benefit in terms of overall survival and disease-free survival. However, there is also evidence for surveillance. The improved imaging techniques have improved the ability to identify complete responders, and if a patient shows complete response on a CT scan after chemoradiotherapy, there's a very low risk of recurrence, about 10%. The MD Anderson series, one of the largest, showed, however, that if there was an equivocal complete response or a partial response, the failure rate was about a third. Yet in those patients, if they had a neck dissection, the failure rate was about 7 to 10%. So neck dissection in that group of patients was essentially mandatory or important. There is also, as a result of the lack of definitive evidence, there is wide variability in clinical practice. In the US, most people practice surveillance. In the UK and France, there's still a considerable proportion of clinicians who practice planned neck dissection. As you well know, FDG Pet is able to not only show anatomical abnormalities but also functional abnormalities, because the tumor cells take up the FDG. As a result, there have been several single center, mainly retrospective series looking at the utility of PET CT scanning and PET scanning in the management of advanced nodal disease. In 2008, we published a meta-analysis of all these papers and studies and showed that there was a very high negative predictive value. That is, if the patient had a negative PET CT scan 8 weeks or more after chemoradiotherapy, there was a 97% chance that their neck was clear of malignant disease. The aim of the study, therefore, was to look at the efficacy and the cost effectiveness of using PET CT scanning to guide surveillance compared to the standard of care of planned neck dissection in this group of patients in a multi-center randomized setting. Patients who had oropharyngeal cancer, laryngeal cancer, or hypopharyngeal cancer with N2 plus disease, who are going to be treated with chemoradiotherapy and who were fit for a neck dissection, were enrolled into the study. The subjects were randomized into either standard treatment, which was planned neck dissection, or into the PET CT guided surveillance arm. In those patients, for those patients, they had the chemoradiotherapy. Then, at 12 weeks after the chemoradiotherapy, they had a PET CT scan. If the PET CT scan was negative, they went into follow-up. If it was positive or equivocal, they had a neck dissection within 4 weeks. Patients were randomized by center, stage, chemotherapy site, disease site, and timing of neck dissection. An equivocal PET CT scan was defined as either a scan that had PET uptake but no abnormality on the CT scan, no anatomical abnormality, or an abnormality on the CT scan, i.e. an anatomical abnormality, but no abnormal PET uptake or mild PET uptake. The primary endpoints were overall survival and cost effectiveness, and the secondary endpoints, as you can see there, disease-specific survival, local regional control, neck dissection complication rates, and quality of life. We aimed for 560 patients to detect a non-inferiority in the overall survival with a hazards ratio of no more than 1.5. It was an intention to treat analysis using Cox proportional hazards models. We recruited over a period of 5 years 564 patients from 43 head and neck centers across the country. There was a quality assurance program with a centralized PET CT core lab that examined every PET CT that was done, and 10% of all pathology and radiology was also centrally assessed. The median follow-up was 3 months. As you can see here from the patient demographics, both groups were well balanced in terms of characteristics. Mean age was 57 or 58. Most of the patients were male, and the majority had oropharyngeal cancer. Most had T1, T2 disease and N2A or N2B disease. About a third of them were randomized or were going to have neck dissection before chemoradiotherapy if they had been randomized to a planned neck dissection. We tested about 80% of patients and for P16, a surrogate marker for HPV, the human papillomavirus, and 75% of them were HPV or P16 positive. And most of them had either conventional radiotherapy or slightly accelerated radiotherapy. Here you can see those patients that were randomized to the neck dissection arm. About a quarter of them were planned to have neck dissection before chemoradiotherapy, and of those, 82% actually had their chemoradiotherapy after the neck dissection. 75% were planned to have neck dissection after chemoradiotherapy, and only 75% of those managed to have the full treatment. Those patients that didn't have neck dissection after chemoradiotherapy, 50% of them had opted not to have neck dissection, and 50% showed progression or were too unwell to have a neck dissection. As for those who were having the surveillance arm, as you can see here, 96% of them managed to have their PET CT scan, and only 20%, almost 20% of them needed it or had a neck dissection. In terms of the results of the overall survival, as you can see here from the Kaplan-Meier curves, there was no difference between the two treatment arms. The hazards ratio was 0.92 in favor of surveillance, and the hazards ratio of 1.5 was outside the 95% confidence interval, meaning that the surveillance arm is strongly non-inferior to the planned neck dissection. Indeed, this hazards ratio of 0.92 rules out an unfavorable difference of 4 or more % in the 2-year overall survival between the two arms. There were no differences in the deaths due to head and neck cancer, and essentially no differences in the deaths due to non-head and neck cancer causes. As you know, the patients who have HPV-related disease are known to do better than those who have HPV-unrelated disease. And so we looked at overall survival by P16 status. And as expected, those who were P16 positive, so HPV related, had significantly better survival rates than those who were HPV negative. However, when you looked at the arms for those, the two arms for those who were P16 positive, there was no difference in overall survival. And if you looked at the two arms in those who were P16 negative, again, there was no difference in overall survival between those two arms. Therefore, PET-CT guided surveillance is as effective as planned neck dissection in both P16 positive and P16 negative patients. When you looked at local regional control, the local regional control rates were exactly the same as were the 2-year recurrence-free survival. Nodal recurrence was essentially very similar in both arms. As I mentioned before, there was a high incidence, of course, of neck dissections in the planned neck dissection arm compared to there was a much lower incidence of neck dissections in the surveillance arm than there was in the other two arms. Yet the complication rates were very similar between those arms. There were more serious adverse events in the planned neck dissection arm, and that was mainly due to the arm where patients were having neck dissection after chemoradiotherapy. But it's important to know that the difference in serious adverse events were mainly due to chemoradiotherapy and not due to the neck dissection part. When you looked at the overall quality of life, patients in both arms had a very similar quality of life. And there was a slight difference in favor of the surveillance arm at 6 and 12 months, but that disappeared by 24 months. We also looked at the quality of life by P16 status, and what we found was that the overall quality of life was better in those who were HPV positive, and they had less symptoms and less problems swallowing. When you looked at their quality of life, we found that those patients who were P16 positive had a much better starting quality of life, but that dropped significantly and considerably during treatment. But then they recovered more after treatment, and therefore they recovered back to almost their starting quality of life by 2 years. Those who had P16 negative had a lower quality of life, generally speaking, and therefore the drop wasn't as much and the recovery wasn't as pronounced. In terms of cost effectiveness, the PET-CT arm was cost effective over the 2-year trial period compared to planned neck dissection. In health economics terms, it was dominant, with a per person cost saving of £1,415, and a small additional benefit in terms of qualities. When you look at the scatter plot, the line there shows the £20,000 per quality threshold for NICE, and PET-CT guided management is associated with 99% chance of being cost saving and a 91% probability of being more effective than planned neck dissection. This plot shows pretty much the same. You can see the wide separation in the probability of cost effectiveness in favor of the PET CT surveillance arm. And if you include the primary care and community health care costs, then the saving per patient is almost £6,000. Our study had limitations. We had the CT part of the PET arm was not a contrasted CT, it was a non-contrasted CT. If we had done a contrasted CT, we'd have been able to compare PET CT to CT alone in surveillance, and that would have given us more information. We didn't have enough data on the equivocal group, and we would have liked to have more data on that group. And I think the study throws some further questions. What about this equivocal PET CT scanning group? The equivocal group on PET CT scans, could we avoid neck dissections, especially if they're HPV positive? Could we use ultrasound FNA? There is some suggestion that that is possible. Also importantly, in the P16 positive patients, does the timing of the PET CT matter? Some suggestion that the patients who are P16 positive take longer time to become PET CT negative. In conclusion, the PET CT guided surveillance arm results in equivalent non-inferior overall survival compared to the planned neck dissection arm, but only 20% of patients had to have neck dissection, with fewer complications and fewer SAEs and a similar quality of life. And importantly, the surveillance arm was more cost effective. Therefore, our recommendation is that PET CT scanning should become the standard of care compared to planned neck dissection. I'd like to thank all the clinicians and centers who participated in the study, and as you can see, there are lots of them. I would also like to thank all the patients for their magnanimous participation, the funders and the sponsors of the study, and especially the NCRI Head and Neck Group for putting the study together, and the Comprehensive Research Network for supporting the study and delivering it. Once again, it's a pleasure to present the study, and it's an honor to present the study on behalf of the PET Neck Trial Management Group. Thank you very much.